you very much for including me in this session. As Dr. Khanna just noted, I will be reviewing the conclusions of a KDIGO controversies conference on blood pressure and volume management in dialysis. Some disclosures. In 2019 in Lisbon, Portugal, KDIGO convened a controversies conference on blood pressure and volume management in dialysis. Attendees hailed from all regions of the world and represented areas with diverse practice patterns as well as diverse resources. And what I'd like to first emphasize is that this was absolutely a controversies conference. This was not a guideline conference. Dr. Cheung will follow me with a guideline conference, but we were a controversies conference. So as such, we did not seek to develop guidelines, and instead the focus was on summarizing the evidence, assessing the quality of evidence, exposing evidence gaps, and really outlining future areas of research based on those gaps. The conference focused on 4 broad topic areas: blood pressure measurement and targets for individuals receiving maintenance dialysis, pharmacologic interventions for blood pressure abnormalities, the dialysis prescription as they related to blood pressure and volume, extracellular volume assessment and management with a focus on technology-based solutions, and finally, volume-related patient symptoms and experiences and non-pharmacologic interventions for blood pressure and volume abnormalities. For the purpose of this presentation, I'm largely going to focus on the conference as it relates to the blood pressure findings, including measurement, targets, and management. However, I did want to summarize some of the volume management strategies because it's really impossible to extricate blood pressure management and volume management on dialysis. So in terms of volume management, particularly for end-center hemodialysis, although this had some application to the other modalities as well, participants really appreciated the fact that we needed to balance the harms of leaving our patients volume expanded versus the harms of leaving them hypovolemic, whether or not that was from taking too much fluid off and misestimating their dry weight or using too rapid of fluid removal rates. So ultimately, and again, the data did not rise to a level where very firm recommendations could be made about what's the best way to achieve this balance. But in terms of volume, conference attendees concluded that managing blood pressure and volume in dialysis requires an individualized approach with integration of numerous clinical dialysis treatment and patient factors. So volume management in dialysis patients, again, across all modalities, should not be a one-size-fits-all approach. So let's look at the blood pressure findings. First, when we manage blood pressure on dialysis, we certainly have numerous measurements to pick from. We have routine dialysis clinic measurements, and this is for end-center patients. We have pre, intra, and post-dialysis measurements. In clinic environments, you can certainly do standardized blood pressure measurements, whether this is in an in-center environment or at a home therapies visit. You can do ambulatory blood pressure monitoring, and you can do home blood pressure measurements. One of the challenges that we have, particularly among our in-center HD patients, is that we know that blood pressure increases in the interdialytic period. And so when we are selecting a time to measure blood pressure, we need to consider the fact that we are really not in a steady state between our dialysis treatments. There has been evidence over the years, and as you'll see, this is data from 2007, but quite frankly, there have not been any more studies that have found anything different from this in the intervening 15 years. What we know is that both home blood pressure measurements and ambulatory blood pressure measurements in general are better predictors of outcomes, both all-cause mortality as well as cardiovascular mortality and cardiovascular events. So as such, conference attendees suggested that home blood pressure monitoring may be the best approach to diagnosing hypertension or other blood pressure abnormalities among dialysis patients. Specifically, home blood pressure monitoring is recommended by the American Heart Association and the European Society of Hypertension, and it correlates more closely with ambulatory blood pressure monitors, those 24-hour monitors, than our end-center pre- and post-dialysis blood pressures. And finally, as I just showed you in the prior slide, it is a better predictor of all-cause and cardiovascular mortality compared to measurements taken in-center. Now, how do we go about home blood pressure monitoring? Among end-center patients, the suggestion is to have patients take their blood pressure twice a day. preferably at different times a day, in the morning and evening, or at least adjusting the times and recording them. And then some felt that it was important to do this after the midweek session, such that you would be most likely to be at a relative steady state for volume. Although I would argue, I'm not sure our dialysis patients, particularly our in-center HD patients, are ever in any form of a real steady state. Now, while this was felt to be likely the best approach to diagnosing hypertension, some did question whether or not it was feasible to do in practice. And some of this questioning came from some of the experiences in the blood pressure and dialysis study. And in that study, they were asking patients to do home measurements. And in that study, only 22% of participants actually achieved at least 4 measurements per month. However, I think that there is some reassurance to that. There was a recent pilot feasibility study published that compared home blood pressure versus pre-dialysis blood pressure, so versus those in-center hemodialysis blood pressures. And what they found was among the participants in this, and this was a small study, but it was 50 participants, in that they found that across the 16-week study, when they were asking patients to do 2 home blood pressure readings per week, that 94% of those 50 patients were able to adhere to that, suggesting that it may be feasible to use home blood pressure monitoring. So thus, to diagnose hypertension, conference attendees recommended considering home blood pressure measurements. Certainly, 24-hour ambulatory blood pressure monitor is an excellent alternative, but that was felt to be infeasible, and in many areas of the world was simply either not available or was cost prohibitive. So what about blood pressure targets? Meta-analysis data tell us that lowering blood pressure among dialysis patients does appear to decrease mortality. However, we worry that lowering blood pressure too much may have adverse consequences. This is, again, data from the blood pressure and dialysis study, and it was a pilot study I'd like to emphasize. So again, we are not making recommendations on these data. We are using them to highlight areas that we need additional data and for further study. But in this particular study, they successfully randomized 126 hypertensive hemodialysis patients, one to an intensive arm and one to a standard arm. They had excellent separation of the 2 arms. The investigators are to be commended for that. But ultimately, what they found was those patients that were randomized to the intensive arm, which was a pre-dialysis systolic blood pressure, and these were standardized, of 110 to 140 millimeters per mercury, that those patients appear to have increased risk for intradialytic events, including intradialytic hypotension and symptoms such as cramping and nausea and vomiting, suggesting that we need to be careful with how low we shoot in our blood pressure targets. So ultimately, conference attendees concluded that thresholds for blood pressure treatment and blood pressure treatment goals among individuals receiving hemodialysis can, and this is true for peritoneal dialysis as well, can only be established based on prospective randomized trials, and the current evidence absolutely does not meet this standard. As such, though, we have to continue to practice. So in the absence of high-level dialysis-relevant evidence, conference attendees felt that it was reasonable to extrapolate blood pressure thresholds and targets for interdialytic blood pressure, so blood pressures at home between dialysis treatments among those in-center patients, from current hypertension guidelines for the general population. But again, they emphasized, and this was similar to the emphasis around volume management, that an individualized approach is necessary. They recommended considering intradialytic and interdialytic blood pressure patterns, certainly the patient's volume status, comorbidities, and frailty when selecting a target. Now, what about treating blood pressure once you have established that hypertension may be present? So once we've diagnosed hypertension, we tend to use, blood pressure medication, certainly for blood pressure lowering, but in other conditions, potentially even in the absence of hypertension, sometimes we use antihypertensives for cardioprotection. So when we're using antihypertensives specifically for blood pressure lowering, the focus here was prior to initiating medications that we should use non-pharmacologic treatments. And I apologize, we're missing an N there, but the focus should be on non-pharmacologic treatments. However, if you have done so, meaning you've optimized the volume status as much as possible and the patient's still not at blood pressure goal, then certainly adding and titrating blood pressure medications is reasonable. However, conference attendees emphasize that if blood pressure medications are at all interfering with volume management, i.e. if you're not able to ultrafilter a patient, they're having intradialytic hypotension, they're having cramping during treatment, that it would be important to consider reducing the blood pressure medications to allow for more volume removal. So again, the focus on volume rather than the focus being on medication management of hypertension. Now for cardioprotection, again, conference attendees recognize that oftentimes, particularly in the settings of past MI, heart failure, stroke, a number of cardiac arrhythmias, that patients require antihypertensives for reasons other than blood pressure lowering. And they certainly felt that it was reasonable to initiate or continue blood pressure medications if given for a cardiovascular indication. But again, they emphasized that they would not reduce ultrafiltration, i.e. they would not change the amount of fluid that they were taking off or decrease the amount of fluid they were taking off in order to allow for titration of those blood pressure medications when they were being used for the indication of cardioprotection. So once again, even in the setting of cardioprotection, attendees felt that optimizing volume status should take priority over titrating blood pressure medications. But I would really like to emphasize that I don't think that this is necessarily an evidence-based recommendation. We really don't have the evidence to allow us to say this definitively. Now, as I mentioned, probably the first, the second, and the third strategy for managing hypertension among dialysis patients should be non-pharmacologic. And absolutely, conference attendees recognize that hypertension management requires adequate control of excess sodium and fluid volume. And they felt that initiation or intensification of antihypertensive therapy in a volume expanded patient, it impedes achievement of post-dialysis euvolemia. So that gets at that point of we don't want to be adding on blood pressure medications or titrating existing antihypertensives among patients who are not able to get down to what we believe is their target weight, although I acknowledge that we are often doing that without a lot of objective guidance. So there are a number of strategies for non-pharmacologic management of hypertension, a focus on decreasing dietary sodium, certainly decreasing any additional sodium loading that may occur from the dialysis procedure, better volume management with accurate as best possible dry weight assessments, and even lacking objective measures of volume status, certainly frequent assessment of dry weight with a combination of clinical parameters as well as physical exam. And in cases where it was available, and again, this was something that varied depending on the practice location across the world, there's certainly technologies that can be helpful for establishing the dry weight. And then in some cases, again, this idea of probing the dry weight such that in the case of the antihypertensives, you may choose to hold or decrease the doses of antihypertensives such that you can try to gently drop the dry weight. And then finally, other strategies, certainly using longer dialysis duration, more frequent dialysis, and as much as possible, using home therapies in patients. The conference attendees certainly recognize that there is a pretty good proportion of dialysis patients that still require antihypertensive medications to help with their blood pressure management. And they concluded that patient heterogeneity and scarcity of comparative evidence precludes recommending any one medication class over another for all patients when it comes to selecting an antihypertensive agent. However, they offered that medications considered first line in the general population, ACEs, ARBs, beta blockers, calcium channel blockers, can certainly be considered in end-stage kidney disease and then individualized based on the indication for the therapy and on patient characteristics. They certainly suggested considering other cardiovascular indications when making the treatment choice. So in the settings of heart failure, MI, arrhythmia, beta blockers may be preferable. And then there was also a possible preference for ACEs and ARBs with the idea that there might be some help with preserving residual kidney function for these agents, particularly among patients receiving peritoneal dialysis. But again, this was somewhat controversial and cannot be said with assurance. The other factor to consider when choosing an antihypertensive agent is the dialyzability of those agents. And first of all, conference attendees very quickly identified that there are no randomized controlled trials regarding dialyzability and outcomes. So they said that it was reasonable to consider intradialytic blood pressure patterns with regards to dialyzability of antihypertensive medications. And what I mean by that is to consider using dialyzable medications if a patient has frequent intradialytic hypotension, and among patients who have intradialytic hypertension or who just have an elevated blood pressure over the course of most of their dialysis treatment, that using non-dialyzable medications in those patients may be preferable. So in summary, at this KDIGO Controversies Conference, attendees concluded that managing blood pressure in dialysis requires an individualized approach with integration of numerous clinical, dialysis treatment, and patient factors. But the resounding conclusion from the conference, which is why it was a controversies conference, is that there is a clear and apparent need for randomized controlled trials and additional study in this area, because really across the board, we lacked evidence to make very strong recommendations. In terms of thinking about future areas of research, I'm going to just highlight the ones that related to blood pressure here. But in terms of blood pressure measurements and targets, the main focus was still on investigating and determining what the optimal blood pressure target or threshold for hypertension treatment should be, based on the U or the J-shaped association that we see in observational studies, and data like that I showed you from the blood pressure and dialysis study that suggest that lower targets may, at least in some patients, be harmful. It's very clear that we're still not sure what the diagnosis threshold for hypertension should be in our patients, nor what the target we should be aiming for once we do have patients on agents. Now, in terms of agent selection, this is absolutely an area that is ripe for future research. Conference attendees recommended conducting head-to-head randomized controlled trials of different medication classes and looking at their effect on blood pressure, which could be measured by ambulatory blood pressure monitors or home blood pressure monitoring. And also with some consideration of potential patient-reported outcomes, given that at least in some of the pilot studies, there has been some suggestion that treating blood pressure may lead to some patient symptoms. Finally, there was also real interest in better understanding the effects of diuretics on not just blood pressure, but on cardiovascular outcomes and residual kidney function. There's more data about this among peritoneal dialysis patients, but not all of it is high quality, and there's certainly a dearth of data regarding this topic among hemodialysis patients. So I would encourage you to visit the full manuscript, which was published in Kidney International in May of 2020, which summarizes and expands upon the information I've given you today around blood pressure, and you can find the recommendations in more detail about volume management. And with that, I will close and I believe pass it back to the moderator.
Thank you, Dr. Flythe. We have 5 minutes. If you would like to take the question now, or we can wait till the end.
I'm happy to take them, but I believe that we were instructed to wait till the end.
All right. Then we'll move on to the next one. Before I go on to the next topic, I just need to apologize. I forgot to mention this session was presented in cooperation with the Kidney Disease Improving Global Outcomes, or we all know as a KDIGO. I thank the organizers for offering to present this during the ABC, and we have been doing it for the past several years. Thanks for this additional education piece. Second talk is by Dr. Alfred Cheung. He's going to present on the blood pressure guidelines. Dr. Cheung is the Dialysis Research Foundation Presidential Endowed Chair, Professor of Internal Medicine, Chief of Division of Nephrology and Hypertension, and Vice Chair of Research at the Department of Internal Medicine at the University of Utah. He has multiple areas of interest, and today we are going to hear from him about the KDIGO guidelines regarding the blood pressure management. Dr. Cheung.
Thank you very much. Is this sound projecting fine? Okay.
Yes, so far, at least we are hearing well.
Okay. All right. Well, thank you very much. My assignment here is to talk about the KDIGO guidelines for blood pressure management in CKD and specifically non-dialysis. I hope that this is of interest to the audience of the ADC. And my co-chair of the guideline is Hans Mann from Germany. Here's my disclosures. Probably of particular relevance is that I was an investigator in the SPRINT trial, but I would try to be as objective as possible when we talk about the SPRINT trial. So the work group for this guideline has international reputations, extensive experience in CKD and hypertension. The evidence review team is the Cochrane Kidney Transplant team from Australia. And the work group used the GREAT methodology that is rigorous. This picture was taken from the Controversy Conference in Edinburgh several years ago. So the first guideline was published in blood pressure, the first and only guideline published by KDIGO in 2012.
Dr.
So
Cheung,
we are now.
Excuse me, we can't see their slides. The slide sharing is not working.
Oh my goodness! Oh, you cannot see any of those slides I just showed. That is a problem. Okay, hang on a second here. I'm sorry that
screen, that should show.
You cannot see the. Hang on a second here.
Can you see that green button with the arrow upwards?
Is it okay now?
Yeah, now we can see it.
Okay, all right. Well, I will. All right, so let me continue here. Here's the work group. And the question was that what is new since 2012, since we had last had the KDIGO guidelines published? Number one is that the systolic blood pressure trial was published in 2015 with a number of sub-studies and number of publications published since then, including the SPRINT Senior, SPRINT CKD, and SPRINT Mind that dealt with cognitive function and the brain MRI. So there has been more work and emphasis on the technique of blood pressure measurement. There have been large meta-analysis of blood sugar trials in CKD and non-CKD populations. And there has been publication of blood pressure guideline by various organizations. Some of them also touch upon CKD. So because of these updates, we felt that the KDIGO should also have an update of the guidelines. So the timeline for this guideline was as follows. There were public commentary of the scope of work in 2018. After we've completed the draft, the guideline, it was sent out for public commentary for about 1.5 months, I believe, in the beginning of 2020, a year ago. And then all the comments were taken back to the work group to carefully consider and incorporate it as appropriate. And the guidelines was published online by International about a week or so ago. So there are 5 guideline chapters. In red are 2 chapters that I will discuss today. The other chapters were also updated, but there were not some drastically different. So because of interest in time, I would not discuss those. But chapter 1 is on blood pressure measurement. We will discuss some more. The second chapter is on lifestyle treatment and lowering blood pressure, specifically for lowering blood pressure for CKD patients. Chapter 3 is blood pressure management in terms of target and also drugs in the CKD population with or without diabetes. Chapter 4 is management of kidney transplant recipient. And finally, chapter 5 is blood pressure management in children with CKD. So chapter 1 is a new chapter. Recommendation 1.1 is that we recommend standardized office blood pressure in reference to routine, other people call it casual, routine or casual office blood pressure for the management of high blood pressure in adults, so evidence 1B. Dr. Flythe has alluded to standardized blood pressure, but I will go into a little bit more in the next couple of slides. And the standardized blood pressure management is super important. I want to emphasize it is mandatory for the blood pressure target that I will discuss in chapter 3. Without the standardized blood pressure measurement, the target that we'll describe in chapter 3 actually does not apply. So this is extremely important. Okay, so what is standardized blood pressure measurement? The key for standardized blood pressure measurement is really the proper preparation. Abstinence from caffeine, exercise, and smoking for at least 30 minutes. To decrease the stress, the feet should be on the floor and the arm and the back supported. Should be quiet. Not only you, this patient should not be talked, but should not be talked to by the providers or nursing staff. And they'll be relaxed for at least 5 minutes, no fighting with a spouse. And the cup size got to be correct and properly positioned, and then validated equipment. It's not necessarily automated, but the equipment got to be validated and good. So that's standardized blood pressure measurement. So why are we so emphasizing so much on blood pressure, standardized blood pressure measurement? Because the correlation between standardized and routine or casual clinical practice measurements are really very, very poor, as we can show it on this slide in SPRINT, where we have 3,000 patients, 30% of CKD, so pretty big sample size, right? About 900 CKD patients. What you see here on this figure is the x-axis is the mean systolic blood pressure, and the y-axis is routine blood pressure in the office minus the standardized trial blood pressure. So you can see the solid line above 0, right? So what it means is that the mean blood pressure among all 3,000 participants is about 7.3 milliliters of mercury higher when you do casual blood pressure compared to standardized blood pressure. Okay, so you say, good, I have a fudge factor to work on. But no, unfortunately, you can see the orange dots are all over the place. They are not closely hugging the horizontal line. Okay, and the 95% limits of agreement is gigantic. It's plus 45 to minus 30. Right. So sometimes it is higher, sometimes it's lower. And likewise, you can see the standardized blood pressure. You see the same thing. Okay, so the routine blood pressure is 4.6 higher, but again, you can see the blue dots. They are all over the place. Right. So the conclusion of this slide is that routine office blood pressure or casual blood pressure is generally higher than standardized. Wrong typing that than standardized office blood pressure. But it can be much higher, and it can even be lower. So therefore, there's no conversion factor. You cannot convert one to add to the other. You cannot say that I'm just going to subtract 7, subtract 5. Right? You cannot do that. And so in the individual patient, there's really no correction factor. So if you do not have careful, correct measurement of the blood pressure in the clinic, we really do not know what the patient's real blood pressure is and how to target the blood pressure. Right? So very, very important. So standardized blood pressure measurements, the advantages is that it minimizes over-treatment or under-treatment of the high blood pressure. And it's importantly is it employed in large randomized trials such as the Accord trial and Sprint trial, and Sprint that we'll talk a little bit more about. Right? The disadvantages, it does require more time of the patients in the preparation and staff in clinic. And then for the same matter is that you require the staff to be trained and retrained to do it properly and not sloppily. Right? We can talk more about it in the Q&A session if you like about the practicality. Okay, so there's a practice point. These are less evidence-based, so it's just a recommended as practice point, but not as guidelines. One practice point is that the oscillometric blood pressure device may be preferable to manual device for standardized office blood pressure measurement. Okay, so oscillometric is preferable to manual. The automated office blood pressure, either attended or unattended by medical personnel, either the nurses in the room or not in the room, may be preferable method of standardized office blood pressure measurements. Okay, so automated may increase the likelihood of adherence to proper blood pressure measurement protocols, and it removes the potential source of inaccuracy of manual measurements. It may reduce white coat effect and free the staff to do something else. And importantly, automated blood pressure measurement are used in large randomized trial and also prospective cohort studies. Okay. But the important thing to emphasize is that what machine you have, automated or not, oscillometric or not, really is not the key thing. The key thing is that the patient needs to be properly prepared. Right? That is the key feature. So recommendation 1.2, this is a hot topic, obviously. You heard Dr. Flythe talking about home blood pressure measurement. We suggest that out-of-office blood pressure measurement with ambulatory blood pressure measurement or home blood pressure monitoring be used to complement standardized office blood pressure reading and the management of high blood pressure. The evidence is 2B, okay? Well, why is it the recommendation is not very strong, even though we do not dispute that home blood pressure measurement, ambulatory blood pressure monitoring correlates well with long-term outcome. In fact, it might correlate better than office blood pressure management measurements. However, there are no large trials, outcomes trials, that's based on home or ambulatory blood pressure measurements. So we do not really know what values we should use. That is the main problem. Now, we talk to chapter 3, which is the blood pressure target. The recommendation is that we suggest that adults with high blood pressure and CKD be treated with a target systolic blood pressure of less than 120. When tolerated, using standardized office blood pressure measurement, the evidence is 2B. Okay, it's not very, very strong. Okay, the benefits and harm of this recommendation in CKD population is less certain in the following categories: diabetes, less certain; advanced CKD, stage 4 and 5; heavy proteinuria, probably over 1 gram per day; individuals who have blood pressure around 120 to 129 to start with, because that is the inclusion criteria for the Sprint trial, that patients with 120 to 129 to start with were excluded from the Sprint trial. Patient with very low diastolic blood pressure, perhaps let's say about below 50, right? Somewhat low diastolic blood pressure is not a contraindication. Very old, we will talk about 90, perhaps over 90 years old, all those who are very frail living in nursing home, or those who have severe hypertension, let's say the systolic blood pressure over 150 while on 4 drugs, right? We are less certain about these, okay? So, but the key thing is that individualization is the key. But that doesn't mean that you should not have a target in your mind and know the literature, right? So it's probably reasonable is to target 120 in almost everybody, but less certain in these subgroups. And then if the patients cannot tolerate it, you back off, right? So that's individualization is the key. So one might ask, should we separate out for two different recommendations, one for all the other CKD and the other for this subgroup? And the work group discussed this quite a bit and they decided against it for two major reasons. Number one is that even though the evidence is less strong, it doesn't mean that less than 120 is not appropriate for these patients. Number two is that if you want to go by 130 or even 140, the evidence for many of this subgroup is really, really not there. Okay, why should it be 130 for CKD stage 4 and 5, for example, right? So for those reasons, we decided we're going to give one guidelines for all CKD patients. So the SPRINT trial is a major evidence factor, and the SPRINT trial is 120 compared to 140, lower than these two targets. Compare those two, and the primary outcome are major cardiovascular events. It's not kidney events, but major cardiovascular events. And you can see that in the entire cohort, the people with systolic blood pressure lower than 120 has a 25% decrease in the hazard ratio. And in the CKD subgroup, you can see it likewise. But here, the confidence interval just barely past 1. Right. But importantly, there is no effect modification by baseline CKD. What that means is that the effects of lower blood pressure on cardiovascular outcome is not dependent on whether you have CKD or not in the whole trial. Right. So similar results were obtained for all-cause mortality. Here, numerically, the hazard ratio is even a little bit lower, 28% benefit. Okay. So we have a question and criticism and talk about, wait a minute, your CKD subgroup statistically is not significant, right? So why are you making that recommendation, right? So this force plots basically show you the same thing as the last graph, except that it also gives you the potential effect modifiers beyond CKD. All right, here you can see that the dotted vertical line has a ratio of 0.75, you see, for the whole population. And those CKD seems to have a little bit less effect, but importantly, it's statistically not different from those who do not have baseline CKD. So you have to take the whole cohort into consideration, right? So that's why it's important to show that this entire SPRINT cohort has positive results. But if you want to dissect it into a subgroup, then you have the same question you have to ask. Do you treat females or not, right? If you look at the female and male, the females are not still significant by itself, right? But the study is not powered for specific gender, right? So if you can go further and further, well, what about female with Caucasian? Are they statistically significant or not? What about female Caucasian living in Boston? Are they significant or not, right? So you obviously cannot do that. The trial has to be taken as a whole cohort and not by the subgroups, provided that the subgroups are adequately represented in the trial. So what about diabetics? And that is was studied in the ACCORD trial. You can see that the top here, the SPRINT trial, show a 0.75 hazard ratio comparing intensive blood pressure with standardized blood pressure. So, but the ACCORD trial overall, in both glycemic arms, ACCORD not only test blood pressure, but also test intense versus less intense blood pressure, right? So overall, it's not quite significant. It's about 0.81, right? And the confidence interval cross 1. So it's almost significant, but not quite. But if you look at the ACCORD trial separately, those with intensive glycemic arm, which do poorly anyway, right? Then low intense blood pressure has no effect. But if you look at the standard glycemic arm, not very tight control of glucose, here in this group, when you have intense blood pressure lowering, you actually have a similar cardiovascular effect as we've seen in the SPRINT trial. So overall, what's the core trial and SPRINT trial is really the results are really quite comparable to each other. But I do want to admit that I do not want to be cavalier about the evidence. The core trial, the primary outcome is not statistically significant. So back to the SPRINT trial, what about the intense blood pressure on not only for cardiovascular outcome and all-cause mortality? What about dementia that we do care about, right? Even though we care more about the kidney than the brain, but we do care about the brain, right? So here you can see that that's the primary CNS outcome was statistically not significant. But one step before dementia, here you are talking about composite of dementia, and one step before that, which is mild cognitive impairment, which is actually is statistically significant. So I would say that it is quite suggestive that lowering blood pressure below 120 actually helps cognitive function. That is pretty big deal. Okay, there are not too many things that actually help cognitive function, including drugs. Right? So what about people worrying about adverse events? I would say that people particularly worry about syncope and injurious fall, and it is really not significant. Hypotension, syncope, injurious fall is not significant between intensive blood pressure and standardized blood pressure. There's some difference in high potassium, low potassium. But then in the very bottom, serious adverse events, SAE, are not different between the two arms. There was some increase in AKI on ARF with intensive blood pressure lowering. However, the more detailed examination showed that the AKI suffer from standardized blood pressure is mild, is complete resolution, about 90%, does not usually require RLT, about 4 or 5%, and do not lead to ESRD. Right, so it's not severe AKI we're talking about. What about elderlies that many people are concerned about? Intensive blood pressure lowering in people who are over 70 years old, also seems 75 years old, the SPRINT senior, is also helpful for CVD and also helpful in all-cause mortality, even over 75 years old. It is beneficial. Numerically, it's even better than the whole population or the younger population, over 75 years old, okay? And there's no difference, again, in total serious adverse events, orthostatic hypotension, injurious fall, between the two blood pressure arms. And the follow-up population, even over 80 years old, okay, with 1,100 patients, you still benefit in cardiovascular outcome, survival, and cognition. Very, very important finding, even over 80 years old. Right? And similarly, CKD patients over 75 years old, you still have seen this benefit. Just finally, 2 slides on kidney outcomes. We talk about intensive blood pressure lowering on cardiovascular and all-cause mortality and cognition. What about kidney outcome? Well, the earlier from the ASK study, Larry Apple will tell us that during the trials, there was no difference between lowering blood pressure or higher blood pressure. What that means is that the green line is not different from the orange line in the only trial section on the left, right? But after the trial, when patients are no longer following the target, in those who have high proteinuria at baseline, then lower blood pressure is better for the kidney. Okay, but this is post-trial data. Okay, lower blood pressure in those with proteinuria, you benefit from lowering blood pressure. Right, but the blood pressure in the S trial is not aimed at systolic; it's aimed at mean arterial blood pressure. What is systolic? The SPRINT trial told us during the first 12 months. If you have intensive blood pressure lowering, you actually have a faster drop of of GFR, but not by much, by about 2 mL per minute or so. Okay, but in the subsequent 3 years or so, that the difference is still statistically significant. The intensive arm is lower by about 0.47, less than half mils per minute per year, compared to 0.32. Overall, either group has not very fast decline in GFR. Right? These are people with not very severe CKD. I agree. Right? So even though it's statistically significant, but the decline in GFR in the standardized arm is quite small. Conversely, albuminuria is lower than intensive arm, right? So you have somewhat contradictory result in the SPRINT trial here. So the question is uncertain whether this less albuminuria in the trial phase of 3.5 years, does it translate into a long-term benefit in GFR? We do not know. We are not certain. So summary is that what is the rationale that we are targeting systolic blood pressure less than 120, specifically in CKD? Number one, we talk about it, is that it must be standardized measurement. Routine measurement is just too erratic. Standardized measurement in the office is what we're targeting. Number two, systolic blood pressure less than 120 seem to have favorable cardiovascular, brain, and survival benefits, and favorable benefit to risk ratio even for people over 75 years old. However, do not count on it to be renal protective compared to 140. We're not certain. The last certainty does not mean that it's not there. Okay, with diabetes, in lower GFR below 20, heavy proteinuria greater than 1 gram, and very old, maybe 90 years old, or very frail, okay? And here, we're not even sure if optimal systolic blood pressure should be 130, 140. We're not sure, okay? The guidelines are useful, but individualization is the key. Thank you very much for your attention.
Thank you, Dr. Cheung. We'll move on to the third presentation by Dr. Babitt. The title of the presentation is Optimal Management in Anemia. Dr. Babitt is received her MD degrees from Harvard Medical School and the MIT Health Sciences and Technology program. She is currently an associate professor of medicine at Harvard Mass General Hospital, and she's the director of translational research in the nephrology division at the Mass General Hospital. Dr. Babitt, please.
Great. Thank you again for the invitation to talk. I'm going to talk to you today about optimal iron management in the anemia of CKD. Disclosures are shown here. So I just want to take a brief step to talk a little bit about the pathophysiology of anemia of CKD. As this audience, I'm sure, is aware, there are two important ingredients to make blood cells. First, we have the hormone erythropoietin that's made by the kidney that acts to stimulate the red cell production in the bone marrow. And we have the mineral iron, which is an essential component of hemoglobin. Iron mainly comes through recycling of red cells. When they get old, they get taken up by the macrophages, which can store the iron and release it into circulation as needed. A lesser amount of iron comes through absorption from the diet. The key mediator of systemic iron homeostasis is the hormone hepcidin that's made in the liver and is excreted by the kidneys. And the function of hepcidin is to bind to the transporter ferroportin and cause it to get internalized and degraded. And ferroportin is the gatekeeper controlling iron absorption from the diet and iron release from stores. So what happens in kidney disease patients is they have numerous disturbances in these homeostatic mechanisms. Patients have a decreased production of erythropoietin. In the setting of uremia, there are inhibitors that block the action of erythropoietin on the bone marrow through mechanisms that we don't fully understand. Many patients have also a shortened survival of their red cells and increased blood loss due to blood trapping and dialyzer tubing, frequent phlebotomy, and increased tendency for bleeding. this not only reduces hemoglobin levels directly, but by reducing the stores of iron in the body, actually reduces the amount of iron that's available to be recycled. And finally, patients with kidney disease have underlying inflammation, which is a major stimulator of hepcidin production. This, combined with the reduced clearance of hepcidin by the kidneys, leads to impairment in dietary iron absorption and impairment in the release of iron from the stores. And therefore, patients with kidney disease can have two disturbances in iron homeostasis. One that we call absolute iron deficiency, which means their total body iron levels are low. So both the stored iron, as we measure by ferritin, and circulating iron, as we measure by transferrin saturation, are both low. And patients can also have what we call a functional iron deficiency, where the stores of iron may be normal or even high, but because of this hepcidin blockade, the iron is not able to be efficiently released into circulation as needed for red cell production, and this leads to iron-restricted erythropoiesis. Now, based on both of these abnormalities, of course, the standard of care for treating anemia and kidney disease has two prongs. One is the use of erythropoiesis-stimulating agents, and the second is iron supplementation. And it's the iron that's going to be the focus of the talk here today. Now, the function of iron that makes it useful for its biological properties is that it is a transition metal that can readily donate and accept electrons. And that is what allows iron to function in its sort of most famous role in hemoglobin, to carry oxygen. But what probably we don't think as much about as nephrologists, it turns out that heme is a cofactor of a number of other important proteins. And there are other important functional groups called iron sulfur clusters that are functional groups of a number of other proteins that perform a diverse array of functions that are required for all cells, including everything from the TCA cycle to electron transport to DNA synthesis. So iron, even aside from red cell production, is really essential for life. But the same property of iron means that it can participate in this so-called Fenton-mediated reaction and can generate free oxygen radicals that can be damaging to cells and tissues when in excess. And of course, the most clear clinical manifestation of this risk is diseases of genetic disorders of iron overload, like hereditary hemochromatosis and thalassemia, where it is the excess iron depositing in organs from the liver to the heart to the endocrine glands that leads to organ dysfunction. But even outside the massive iron overload that's seen in these genetic conditions, there is some evidence that excess iron levels can be associated with more common disorders, everything from diabetes to neurodegenerative disorders to cardiovascular disease, acute kidney injury, and malignancy. And as all cells in our body need iron to grow and proliferate, so do infectious organisms. And so there is also the potential risk that iron can also predispose to certain types of infections. So because of this need for iron, but too much iron has the potential for toxicity, we have to sort of balance iron levels appropriately in the management of the anemia of kidney disease. So of course, the current guidelines are quite old at this point. They were last published in 2012 by KDIGO. And in general, the recommendations are that we give a trial of iron if we're trying to improve hemoglobin levels without starting ESAs, or we want to try to decrease ESAs. And the transferrin saturation, or TSAT, is less than 30%, and the ferritin is less than 500. But it was recognized at the time these guidelines were put out that there are a lot of limitations and caveats. One important one being that transferrin saturation and ferritin have limited sensitivity and specificity in CKD patients of what the bone marrow iron stores are and what we can expect the erythropoietic response to iron supplementation to be. It was also recognized that no sufficiently powered interventional trials were available that had tested different triggers or targets for iron. And there were very limited long-term safety information about iron. It hadn't been exposed to the rigor of the randomized controlled trials that had occurred with ESAs. Now, this was the state in 2012, but a lot has happened since then. So KDIGO decided to organize 2 controversies conferences on optimal anemia management. The first was held in Barcelona in December 2019. And that was co-chaired by Tilman Juk and myself, and you can see the group leaders here. And we were tasked with reviewing the latest evidence, exploring new and ongoing controversies, proposing a research agenda and assessing change implications for the 2012 anemia guideline. This first conference focused largely on iron, and there is a second conference that is planned in the end of 2021 to discuss the novel anemia therapies, in particular the hypoxia-inducible factor prolyl hydroxylase inhibitors, or HIF-PHIs. So what is new since 2012? Well, one of the most important things is we now have new prospective randomized controlled trial data, in particular, the most important of which is the pivotal trial. So this was a prospective randomized controlled trial in over 2,000 incident hemodialysis that compared a proactive strategy of IV iron dosed at 400 milligrams per month in the form of iron sucrose. And this was given routinely every month and only withheld if the TSAT was greater than 40% or the ferritin was greater than 700. And this was compared with a reactive strategy of a lower dose of iron only given if the TSAT was less than 20% or the ferritin was less than 200. This was designed as a non-inferiority trial with the primary endpoints being a composite of non-fatal MI, stroke, heart failure, hospitalization, or death. Secondary endpoints and median follow-up are shown here. So as you can see, in the proactive arm, they tended to have higher TSATs than the reactive arm. And an important thing to point out is in the reactive low iron arm, many of the patients had TSATs less than what we would consider, consistent with iron deficiency of 20%. Looking at ferritins, again, this was higher in the proactive arm, generally in the 600s range. And in the reactive arm, again, many of the patients fell below the threshold consistent with iron deficiency of less than 200. Looking at the primary outcome, what they found was that the proactive high-dose arm was non-inferior to the reactive low-dose arm. And because it achieved non-inferiority, they were able to assess for superiority. And you can see there was a small but significant improvement in the primary efficacy endpoint, the composite of non-fatal MI, stroke, heart failure, hospitalization, or death. Looking at secondary outcomes, you can see that ESA usage was lower in the proactive arm, as were blood transfusions, and there was no increased risk of infections. And so the implications of this trial are that we now have good RCT trial data to tell us that we should be avoiding a ferritin of less than 200 and a TSAT of less than 20% in hemodialysis patients. This seems harmful. And that this proactive strategy of using regular IV iron and holding it only if the ferritin is above 700 or the TSAT is above 40% resulted in improved outcomes and was safe, leaving open the possibility that perhaps this strategy is the optimal one. But it still remains unknown whether lower or intermediate dose or target strategies might have been sufficient. And we still don't know the upper limit of TSAT or ferritin in terms of safety, ESA dose reduction, or patient outcomes. And I think it's important to caution that although the quality of this type of data is less, there are retrospective observational data that do raise some concerns that too intensive iron therapies, more intensive than the proactive arm of pivotal, could be associated with an increased risk of adverse events. And here's an example of such data. This is a paper published in CJSON about a year or two ago. It's a retrospective cohort study of over 13,000 hemodialysis patients that were assigned to one of 5 common IV iron strategies. Results were compared to this baseline strategy 1 that you can see outlined here. And the most intensive strategy was strategy 5. And as you can see, looking at TSAT and ferritins and the amount of iron that were given, certainly this was a more intensive strategy than that used in the proactive arm of pivotal. And with all of the caveats of this type of data, they did see an increased risk of all-cause mortality and infection-related morbidity and mortality. And so certainly, again, raising the concerns that there may be a certain threshold above which too much iron could potentially be harmful. Many more unanswered questions were identified by the work groups. It was recognized that there might be differences between populations and ethnicities worldwide For example, Japanese hemodialysis patients have generally much lower median ferritins than in the US and Europe, possibly related to lower inflammation levels while achieving similar efficacy. So a one-size-fits-all approach may not be appropriate, and we may need more personalization of anemia therapies. We still don't know what the optimal treatment regimen for non-dialysis CKD patients is. We don't have as much RCT trial data to inform us there. There's still the question of whether there might be a benefit to treating iron deficiency beyond anemia. There's some evidence, for example, from the heart failure literature that treating iron deficiency beyond anemia could improve heart failure outcomes, but this is an understudied area in CKD. And additionally, we still don't really know the optimal treatment algorithm between the relative use of iron therapy and ESAs in anemic CKD patients. You know, it's clear that you can dial up either one, you can increase iron or ESAs and still achieve the same hemoglobin levels, and the relative amount of each that's optimal still remains unclear. And as new anemia therapies come out, that will need to be established for each of these new therapies. There was also recognition that there's understanding about new links between anemia, in particular iron, erythropoietin, and inflammation, and mediators of mineral and bone disorders in CKD. In particular, it's been recognized that higher levels of FGF23 are associated with iron deficiency, inflammation, and anemia in patients. And there are animal studies that have demonstrated that iron deficiency, inflammation, and EPO all actually stimulate FGF23 production. And so there's a question about whether they could potentially contribute to excess FGF23 and therefore mineral and bone disorders and additional potential adverse effects that are associated with FGF23 excess, as well as the question of whether iron therapies could help, by treating iron deficiency, potentially help to ameliorate FGF23 excess. There's also recognition that we have new iron therapies out there, including the oral iron preparation ferric citrate, which has a dual role, both as an iron compound and as a phosphate binder. So targets both of these pathways directly. And there's also recognition that there are certain IV iron preparations, not because of the iron itself, but because of the carbohydrate shell that actually stimulate FGF23 production through mechanisms that we don't fully understand. And in patients who have residual kidney function, can cause hypophosphatemia and potential bone complications. And finally, there's some intriguing data, early data in animals suggesting that this relationship may potentially be bidirectional, that FGF23 may in turn have potential roles in erythropoiesis, iron, and inflammation. So there was recognition of these links that are starting to come to light, but we really need a lot more study and research to understand what these links mean and how that impacts patient care. And finally, we have new agents. In particular, I wanted to highlight the HIF prolyl hydroxylase inhibitors. So just a little bit to talk about the biology of how they work. So in the kidney, we have interstitial cells that make erythropoietin. And inside the cells, there's an important transcription factor pathway that's relevant for producing erythropoietin, and that is this HIF pathway, in particular HIF2. There's an alpha subunit that is hydroxylated by prolyl hydroxylase enzymes that are both oxygen and iron dependent. This hydroxylation event recruits a protein called von Hippel-Lindau, which causes ubiquitination and targets this protein for degradation. So when iron and oxygen levels are high, the HIF alpha subunit is degraded and is inactive. Under conditions of hypoxia or iron deficiency, the prolyl hydroxylase enzymes are inactive. This stabilizes the alpha subunit, and it can then partner with the beta subunit and go to the nucleus and induce the production of erythropoietin. And so the way these HIF-PHI agents work, they're prolyl hydroxylase inhibitors, so they actually inhibit this PHD enzyme. And the net effect of this is that no matter what the oxygen or iron levels are, HIF alpha subunits are stabilized, and they act to induce the production of erythropoietin. And so you may ask, well, what would be the potential advantage of this type of therapy? Because we already have, right, recombinant erythropoietin that we can give patients. One potential advantage is that these agents are orally bioavailable. Additionally, because they're stimulating the production of endogenous erythropoietin, the peak levels of erythropoietin achieved are less, and so they can get erythropoietin levels into this range where you can induce erythropoiesis, but potentially avoid some of these super physiologic erythropoietin levels that can be seen with the more traditional ESAs. And certainly we know from trials such as TREAT and CHOIR that when we're using traditional ESAs to target normal hemoglobin levels, this can be associated with the increased risk of adverse effects, things like stroke, cardiovascular events, and mortality. And so potentially, and in those types of studies, secondary analysis have suggested that these adverse events may be related to these higher doses of ESAs and potentially higher erythropoietin levels. And so potentially by achieving lower levels of erythropoietin, this could be favorable regarding some of these adverse outcomes. But of course, we need clinical trial data to tell us if these theoretical benefits are really occurring in patients. And of course, the flip side of this is that erythropoietin is not the only target of HIFs. There are a whole host of other proteins that are regulated by HIFs. And so this raises the concern that proteins involved in malignancy, in vascularization, and so, for example, in diabetic retinopathy, in cyst progression and proliferation, that these agents could potentially have adverse consequences related to turning on these other proteins. But I think it's important to point out that there is the possibility of achieving a therapeutic window. First of all, there are 3 different HIFs, HIF1, 2, and 3, and HIF2 is the main one that regulates erythropoietin. So if you could target HIF2 more specifically, that's one way of achieving some level of specificity. And it's also important to keep in mind that all of these proteins are not turned on at the same time. They have different levels of sensitivity. And one of the most sensitive HIF regulated genes is erythropoietin. So just a little bit of HIF for just a short period of time may be enough to turn on erythropoietin without necessarily turning on all of these other proteins. And additionally, not all of these other effects of HIFs are necessarily harmful. Some of them could potentially be beneficial. And it's clear that one subset of genes regulated by HIFs are in fact related to iron homeostasis. So for example, you may hear that these HIFs, PHIs may actually serve to inhibit hepcidin and thereby improve iron availability. And I think it's important to understand that actually hepcidin is not a direct HIF target. The way that HIFs regulate hepcidin is actually the same way that traditional ESAs affect hepcidin, and that is that erythropoietin acts to stimulate red cell production in the bone marrow. And these proliferating red cells make secreted factors such as erythroferrone, which then circulate to the liver to lower hepcidin, thereby improving iron availability. And again, this mechanism is shared both by traditional ESAs and HIF PHIs. But there are many other iron-related genes that are direct HIF targets. In particular, if you look at intestinal cells that absorb iron from the diet, there are ferroreductases called D-site B that reduce the iron, which is then taken up through an importer called DMT1. And the iron is then exported out the basolateral side through ferroportin. Ferroportin is actually the hepcidin target that we were talking about. And the iron is then loaded onto transferrin for delivery to the bone marrow and other tissues. So it turns out that many of these proteins are actually direct HIF targets. In particular, it's been shown that HIF2 in the intestinal cell directly upregulates all 3 of these proteins. So you can imagine if you are able to increase HIF activity in the intestinal cell, this, by increasing the expression of these proteins, could increase absorption of iron from the diet. And transferrin itself, which is mainly made in the liver, is also a direct target of HIFs, in particular HIF1. Now, whether the HIF PHIs at the doses that we're giving to patients actually have a functional role to regulate these proteins in patients, that is what we need clinical trial data to tell us. But at least in theory, this is a potential benefit of these agents. So what does the trial data show us? So as you know, we are now starting to see phase 3 trials coming out from a number of HIF-PHIs. And I'm just going to review briefly one of the first trials that was published in 2019. So this was a prospective open label randomized control trial of the HIF-PHI roxadustat versus active therapy with epinephrine alpha. It was designed as a non-inferiority trial, and you can see some of the details of the trial outlined here. Essentially, the drugs were dosed to achieve hemoglobin targets between 10 to 12, and no IV iron was allowed in this trial. Primary endpoints were changes in hemoglobin level from baseline, and secondary endpoints are as shown. And what they saw in this trial, and has been borne out by many of the other trials that have been published, is that the HIF-PHI was non-inferior to the epinephrine alpha as far as maintaining hemoglobin levels. So these agents are effective at treating anemia, but the question, of course, remains: do they have any adverse consequences? What are the effects on more hard outcomes? And in this controversies conference, one of the things we discussed was what are their effects on iron parameters? And the answer to that is we still don't really know because there's not enough trial data to show you. But just to review, for example, what they published in this trial is they reported that the HIF-PHI roxadustat reduced hepcidin levels from baseline, whereas the epinephrine alpha did not. And this was statistically significant. But if you look more carefully at the data, what you see is that the main difference was that in the roxadustat arm, the baseline hepcidin levels were higher. And yes, that did go down by the end of the study, but the final levels of hepcidin were similar between the two arms. So in my mind, sort of a less convincing story that the HIF-PHI is necessarily more effective at lowering hepcidin than traditional ESAs. So we need more trial data to better understand that. What about other iron parameters? So if you look at transferrin or total iron binding capacity, which are essentially measuring the same thing, transferrin is a direct target of HIFs, and indeed this did go up in the roxadustat arm, whereas it did not change in the epinephrine alpha arm, and this has been something consistently seen in a number of the studies. Serum iron in this trial did not change in the roxadustat arm, but did go down a bit in the epinephrine alpha arm. So when we look at TSAT, which is the circulating iron measure that we tend to target, this went down in both arms, although it went down a little bit more in the epinephrine alpha arm. But how you achieve this was different, right? So TSAT is iron divided by TIBC. And so in the roxadustat arm, the denominator went up, whereas in the epinephrine alpha arm, the numerator went down. And so there are some differences there. And what the overall impacts on sort of iron utilization, again, this is a question that we need for further data to tell us. And finally, looking at the stores of iron, ferritin, this went down in both arms and it wasn't statistically different from each other. So showing that both of these agents were effectively mobilizing iron in this study. And again, remember, IV iron was withheld, and so this is why this went down over the course of the study. So we now have a number of other phase 3 trials that have been published. And here, this table is just kind of summarizing all the trials that are available in patients who are on dialysis. And there are several HIF-PHIs that have been studied. And overall, important to keep in mind that still the number of patients in these studies is relatively few. The amount of time in this study is relatively low. And many of these studies actually used no comparator or placebo rather than active comparison with ESAs. And it's basically, as I reviewed in the trial that I showed you, it's still too early to really say how these agents are impacting iron parameters and the need for iron therapy. So finally, I'll just conclude by saying that what we found in this conference is that a lot has changed since 2012. We have new RCTs and other clinical trials. We have new therapeutic agents and new biologic insights. There still, however, are many unanswered questions and more research is needed. So please stay tuned for our paper, which is currently under review in Kidney International. Also stay tuned for the second Controversies Conference on novel anemia therapies that is scheduled to happen at the end of this year. But it's clear that we will need new guidelines. And so KDIGO has in fact started the process of the anemia guideline update, which will play out over the next few years. And so finally, I want to thank the folks from KDIGO and all of our conference leaders and conference attendees, as well as thanking you for your attention.
Thank you, Dr. Babitt. Now we'll have a question and answer. I see the question and answer. There's only one question for Dr. Babitt. Would you give IV iron in dialysis patients with the ferritin less than 200, but hemoglobin hematocrit is higher than the target range, like over 11?
Yeah, so this is a good question. And I think this is one of the areas where we discussed that, we don't have a lot of data. There's certainly, some evidence from other diseases like the heart failure literature that suggests that treating iron deficiency outside of anemia may have a potential benefits, at least on heart failure. But this has not been well studied in kidney disease patients. So there's really not enough data to provide recommendations. But personally, I think that, you would want to prevent the development of iron deficiency that can then exacerbate the anemia. So I think that unless there was a contraindication, it would be reasonable, particularly in a hemodialysis patient who's going to be prone to getting worsening anemia over time, to keep the iron parameters above those thresholds.
While waiting for more questions to come, I have a question for either Dr. Flythe or Dr. Cheung. Oscillometric method, manufacturers recommend that it should not be used for certain patients, such as a patient with severe tachycardia or those who have atrial fibrillation. What do you recommend such patients use in terms of measuring blood pressure? How would you advise them? If anyone of you.
Dr. Cheung, I think you're muted if you're responding.
I'm sorry. Okay, so these are the patients with what I did not quite get the problem there.
The this automatic oscillometric method, manufacturers have not validated the blood pressure measurement with people with the atrial fibrillation or have high tachycardia.
Oh, okay. Atrial fibrillation.
Yeah.
Okay. Yeah. So I think that on chapter 1 of the guidelines, we cited that for atrial fibrillation, actually the automated oscillometric measurement is quite good. I cannot attest to other arrhythmia, but specifically for atrial fibrillation, it is still quite satisfactory, and there is literature to support that.
And the elderly with the stiff arteries?
Sorry?
Elderly with the stiff arteries, 80s, 90s.
Stiff arteries, yeah. So there is obviously the elderly, you have a high pulse pressure, but the literature at the beginning of the consideration is that systolic blood pressure seems to be significantly more important than diastolic blood pressure in predicting outcome. So that's why the SPRINT trial is called a systolic blood pressure trial. Right? So despite the fact that you may have wide pulse pressure with stiff artery, the SPRINT trial was still targeting the systolic blood pressure. So how many people actually have stiff artery in SPRINT trial, we do not know, right? But there are 9,300 patients, and they are all over 50 years old, and many of them are over 75. And the systolic blood pressure seems still be beneficial. And furthermore, those with low diastolic, right? So that's what the stiff artery would do. You have a a wide pulse pressure, even those with low diastolic, they still benefit similarly than those with higher diastolic. So the SPRINT trial really is agnostic to to the age and whether the patient have stiff arteries or not.
What is the impact of high output in patients with the large AV fistula with a high blood flow in assessing the blood pressure targets?
Wow, that is a question for Dr. Flythe, the dialysis patient with a fistula. That is, Flythe, Dr. Flythe, do you have any comments on how to deal with blood pressure target there?
Well, I think in the case, again, we're into a data-free zone in terms of what to do at a real population level with this. So I think it ends up being a very individualized decision. And among patients who have a very high output fistula that we think is going to contribute to heart failure over the long term, which there's certainly evidence to suggest that could happen. You know, unfortunately, in those patients, oftentimes we have to ligate the fistula. So I think it's something to watch for. I think that there is ongoing kind of discussion and controversy about whether or not just sort of less high output fistulas may contribute over time to cardiovascular outcomes among patients. And so I think the verdict on that is still out, but populations that are interesting in that particular regard are those stable transplant or those who have moved on to other modalities about whether or not they should retain their fistula.
I have a personal experience of over 10 patients with the transplant, successful transplant, who come into a follow-up in transplant clinic. Many of them go into unexplained heart failure, and they have a functioning AV fistula. Once you close the fistula, their heart failure goes away, and they are back to pretty much a normal state. This
so hence why I made that comment around that particular population. I would say that I share your experience there, and I do wonder if, again, I just don't think we have the data to answer it definitively, but I think from clinical practice, many of us have seen that.
There are some additional questions for Dr. Babitt. What is, in your opinion, the best measure for iron deficiency in ESRD?
So this is one area where, you know, the work group agreed that we need more parameters, because, you know, the agents that are, the tests that we have right now are transferrin saturation and ferritin. TSAT assesses the amount of circulating iron that's immediately available for erythropoiesis, but, you know, it's a very small pool of the total body iron, and ferritin is your measure of total body stores. But we all know that ferritin is also induced by inflammation, so it doesn't necessarily tell you what the iron stores are, particularly in an inflamed patient. And, you know, these aren't necessarily good predictors of responses to iron. There are some other, you know, parameters that some of the CBC analyzers, you know, can measure as far as the reticulocyte hemoglobin content, or other things that, you know, that are already out there that need some more standardization so that they can become more standard of practice. But the bottom line is that we need more assays than what we currently have. And that's an area where we need more work.
Another question, probably we don't have enough studies on this one. Any value of vitamin C supplementation for enhancing absorption and utilization of iron in pre-dialysis?
Yeah, I mean, so there's definitely, you know, sort of looking at sort of the biology of iron absorption and how that works. There's definitely some evidence that vitamin C can improve iron absorption, but whether in, you know, pre-dialysis patients treating with vitamin C actually has any efficacy, this is an area where there's no data that suggests that it's helpful. But again, the theoretical principle certainly exists.
One more question for you. Some nurses hold iron when a patient has a cancer, unless ordered. What's a ground rule for such a situation?
So here for iron in particular, certainly for ESAs, right, there's a lot of literature suggesting that ESA usage can be associated with cancer progression and mortality in a lot of different types of cancer. And so, you know, in general, in the oncologic literature, that's something that you would hold unless, you know, a patient wasn't necessarily going to be being treated for a cure. But that doesn't tell you what to do with patients who have also kidney disease, who might be treated for their kidney disease. And so this is always a discussion that's helpful to have with the oncologist as far as whether, patients where it might be indicated or not indicated. And certainly an informed consent would need to happen with the patient. Now that's with ESAs. Iron is not something that's really been studied that carefully, but there's some interesting literature out there that shows that there are many types of cancers where changes in the expression level of different iron transporters in order to increase the amount of iron in cancers, because cancers need iron to grow and proliferate. And there's an interesting set of papers that was looking, for example, at breast cancer, showing that breast cancers that had changes in hepcidin and ferroportin that sort of favored increased iron actually had worse outcomes. But that's kind of theoretical, right? So practically, what is the impact of our iron therapies on cancer? It's totally not a known area. It's not something that we have data to tell us. So it is an area, I think, where we should at least, that's an outcome that we should look at in the trials that are being done.
Thank you very much for all the presenters. We heard some interesting new developments, and I hope in the coming meetings we'll have more to talk about this. Thank you very much.
Thank you.
Session for today.
Thank you.
Thank you. Bye-bye.